Welcome to this episode of the NLN podcast, Nursing Edge Unscripted, the surface track, and thank you for joining us. This episode is entitled Fostering Well-Being in the Nursing Community, Finding Our Voice to Ask for Support, where we will discuss the current state of well-being in nurses and nurse educators on the heels of a pandemic, nursing strikes, debates on staffing ratios, and many other topics that impact how we perceive our roles and state of wellness within these roles. With that, we will also discuss the stigma associated with mental health and the importance of finding our voices to advocate for help when needed. To help us today, we have a very special guest, Dr. Cynda Rushton. Dr. Rushton is an Anne and George L. Bunting Professor of Clinical Ethics at the Johns Hopkins Berman Institute of Bioethics and School of Nursing, and co-chairs Johns Hopkins Hospital's Ethics Committee and Consultation Service. Dr. Rushton has a rich and extensive experience that includes co-leading and co-chairing several national initiatives to transform moral distress into moral resilience and contributes to expert panels to initiate cultures of ethical practice. She is the editor and author of Moral Resilience, Transforming Moral Suffering in Healthcare. Welcome, Cynda. Thank you for joining us.
Well, I would like to get us started just talking about the words we use, because as we've mentioned, sometimes the vocabulary can get conflated, and it's important that we recognize that the words we use matter and they have implications that we may not recognize. So, Cynda, do you mind starting us off with unpacking for us a little bit about the lexicon around well-being and mental health and mental illness?
That's a great question. And I would add one more to that list, which is the issue around resilience, because these are all terms that are part of our narrative right now. And they are words that have, strict meanings that somehow have, in many instances, been corrupted in one way or another and have kind of drifted far from their original meaning. So to me, the well-being umbrella is an umbrella that encompasses all parts of ourselves, our physical, our psychological, our spiritual, our moral well-being, how we can be whole people in a way that reflects who we really are and how we want to be in the world. The other topic, of course, the word that is used a lot, and we certainly are using it, is resilience, which has many meanings. There's not one unifying definition of resilience, but there's a way in which certain parts of those definitions have been sort of created as memes, that the idea of resilience is about bouncing back. But actually, that is only one small dimension of what it means to be resilient. It means our ability to meet challenges in ways that are healthy, that allow us to create meaning and learn from them, and to grow as opposed to be overwhelmed and degraded by them. And so if you think about that word, sometimes they can become weaponized where, there's this sort of narrative of, don't tell me to be resilient because that puts all of the responsibility on me as an individual. In fact, nurses are already resilient. And they wouldn't be nurses if they weren't, just surviving. Birth is a resilient process. So I think it really matters how we sort of set up the conversation, the dichotomy of, on the one hand, we say either you're burned out or you're resilient. And what we know is that those are actually two distinct concepts, that the absence of resilience is not necessarily burnout. And the converse is also true, that if you are burned out doesn't mean that you are not resilient. It may well mean that the circumstances have exceeded your capacities to meet those challenges, not because you're deficient or lacking, but because they're exceeding anyone's abilities to sort of stay healthy and whole. Then we sort of drill down even further on the mental health, mental illness continuum. And one of the things we often see is we conflate our biases, our understanding of mental illness with the concept of mental health. And when we do that, there's an opportunity where there's a lot of projection of stigma and assumptions about what it means to be mentally healthy. And the mental illness frame, I think, leads us down a path where it can really reinforce some of our biases about being able to be honest about our limitations, about where we're struggling, where we might need support in a more proactive way versus a diagnosis that requires a different kind of intervention. So it is being really specific about where we're locating ourselves in the conversation.
I really appreciate that. And two things that are running for me as I'm hearing all that. One is that being burned out and being resilient are not mutually exclusive. And I also hear in that is that an individual can, in terms of their mental health, their mental health can be unhealthy, but it's not a mental illness. Correct?
Exactly. And I think being able to sort of see that continuum can help us shift from this stigma that goes along with the whole idea. I mean, as a culture, we have so much bias about how we think about mental illness, even within nursing. You know, if you can't see that you have an injury or an illness, then there's all these questions that come up about, well, why don't you just take care of that? Can't you just control that, or can't you fix that? Instead of, applying the very same compassion and curiosity that we would for a person who had heart failure or cancer to a person who may be struggling with mental challenges, of depression or anxiety, or in our workforce right now, PTSD. I think it's a real opportunity, especially right now in our profession, that we really pay attention to those distinctions.
It's so important. And Michelle, I was curious to hear Cynda's thoughts on putting our lens on the nursing workforce in terms of well-being. You think that to transition to that? Excellent.
Absolutely.
So I'm wondering, I'd like us to put our lens of this conversation on the nursing workforce right now in terms of well-being and resilience. And I think there are a lot of factors at play, both for academia and practice, that can really impact resilience and overall well-being. I think about the pandemic. I think about this increased spotlight on litigation for medical errors and the impact it has on systems thinking. And I think about the nursing staff shortage, and both on academic faculty shortage and bedside practice. All of these factors I see having a significant impact on well-being and resilience. And so I'm curious to hear your perspective on what is the state of our well-being as a profession, both in academia and in clinical practice.
Well, it's not great. Let's just sort of tell the truth here. And it's not as if these are new problems. They have been present for as long as I've been a nurse. The pandemic has really intensified them, though, in ways that I've not seen in my profession. And so it's like, we know from lots of data that nurses are experiencing high degrees of depression and anxiety PTSD. We're seeing more an uptick in suicide among nurses, which is a very extreme response to a sustained and often unrelenting stress that nurses are experiencing along with the general public. In my work, we've seen, evidence that alongside all of these things, the levels of burnout are very high. Before the pandemic, they were hovering around 42%. We've heard of it, levels of 60 or 80% of nurses demonstrating symptoms of burnout. And moral injury and moral distress. In one of our studies, 4 in 10 nurses in our sample had clinically significant symptoms of moral injury. So that tells you that there are extreme stressors everywhere. And it's not just in nurses who are delivering direct care, it's in leaders, but it's also in faculty and students who are in this milieu of trying to, respond to this overwhelming and unrelenting pandemic that we've been in. And so I think that it is important for us to pause and to say, probably about half of us have symptoms of depression, that we are anxious, and that it's not a moral failing that we are experiencing these kinds of responses to a situation that really has exceeded all of our capacities. Some of us look like we're doing okay, but truth is none of us have been through this experience unscathed. And so there's I think, an invitation for us to step back and to ask ourselves what's missing from our repertoire. And I do believe that it is, on the one hand, the lack of resources that individuals have themselves to meet these challenges, but that is not sufficient to actually address the system contributions that create the conditions where this extreme stress and distress and moral injury is occurring.
So this is really important. I'm hearing really 2 levels of a concern. There's probably more in there that I may not be picking up right away, but there's sort of this individual moral distress or experience of moral injury that I also feel like is quite, I'm going to use the word contagious for a lack of better words, but if you're experiencing moral injury or moral distress, you're going to be sharing that unconsciously or consciously with other people. So when I think about faculty, if we're experiencing this kind of distress, it's going to be projected and shared and leaked out, maybe even without our intention, in the classroom, in clinical. If we're feeling anxiety, it tends to, and I just even think about that personally as a mother. If I'm feeling some stress at work and I walk in the door and I don't clear that space, everybody's going to get some of that, whether it's just snapping or being short-tempered and if you think about a nurse, feeling that in the context of patient care, how serious that can be for one another, for the morale of the unit, and then for the patient care and family care directly. So that's concerning to me, just the ripple effect. And then I also heard you mention systemic, right? Systemically, if we're not addressing some of the systemic barriers or challenges, then it's just all going to continue to be experienced.
Yeah, I think that's a really good point. The sort of moral suffering that people experience often is related to the gap between what they think they ought to do and what they are actually doing. And I think this is also a time when we, again, back to your point about language, the reason that we're distressed about staffing is because not having the resources to provide care that we know we could under other circumstances creates this dissonance and distress that somehow I'm not fulfilling my ethical obligations to my patients or to my students. And that is a kind of moral residue that stays with us, and it begins to accumulate, and our integrity begins to be degraded. And it has physical and psychological consequences. And what you're talking about, Michelle, I think if you think about it from our nervous system, we resonate with each other's energy. And our nervous system is oriented toward threat. So when we come in with negative energy, we're more likely to start resonating. Everybody else is going to start resonating with that as well. And, you put on top of that, if you think about the features of burnout, emotional exhaustion, cynicism, lack of personal accomplishment, one of the things that's happening and unconsciously the spread of this negative narrative is that our cynicism about our work has been fueled again and again and again by repeating the negative, disempowering narrative about burnout. And so we're inadvertently reinforcing in our nervous system this fight or flight, freeze kind of responses that don't actually help us to be able to connect to each other, to connect to ourselves, and to connect to the resources that we might need to help us to navigate through this particularly challenging time.
And I think what's interesting too is probably people's I don't want to say lack of skill or awareness to talk about moral distress and discomfort, and right. So when I'm experiencing this nervous system disturbance, we'll just call it, or fight or flight, or this elevation, it's felt by others, and then people don't know how to respond to it. So people will then either shut down, or they may even say, "Are you okay?" And I'll be honest, I'll say, "I'm fine." I'm fine, because I'm just trying to keep it together or keep it down. I've learned to stop when I get that kind of input, to stop and check myself. Am I feeling fine? Where am I not feeling fine? Why am I not feeling fine? But that took some time and intention and a long history of experiencing burnout and distress to navigate that space. But if we don't have the language, if we don't have the skills, right, we're not going to connect. We're just going to separate. And I think I've experienced that many times personally, but I'm worried more again about the profession, at this separation that we're experiencing and seeing, and that's concerning.
Yeah, if you think about one of the consequences of the pandemic is in part because everybody was in PPE, we're masked up. We are not in our usual settings, that many people, in the midst of feeling challenged emotionally and physically, they're also socially challenged of isolation. And one of the consequences is we begin to question, do I belong here? Do I belong in this profession? Do I belong in this organization? And it's part of that cascade, of how, when these kinds of experiences accumulate, that if we're not able to notice, as you said, Michelle, that, am I really okay? And how do I then ask for and receive support and resources? I feel like this is one of the big issues in nursing right now. One is, who are we now? And the other one is, how do we create an environment where asking for and receiving support is a norm that we all uphold and honor, and how we then can create systems that make it easier for us to do that, so that the kind of stigma that we often associate with mental health, and that, overlap. I'm mentally ill now because I'm feeling so sad today that I'm depressed, or I'm so anxious I can't focus. The labeling of those experiences as somehow bad or wrong, I think is something we have to really pay attention to in nursing, because we've got a culture where, the survival of the fittest, and we do not have a lot of tolerance. If you seem to be struggling, we're like, well, that's not how to be in our profession. And so I think that's a place where we need to spend some time examining how we're all contributing to that.
As I hear this and I think about this, it makes me think about who I consider might be our most vulnerable in the nursing profession. And I think about our new grads, those who are transitioning to practice, whether they're transitioning to practice at entry level or transitioning to practice at an advanced practice level. And we know the rates of retention, we know the risk to leave the profession, especially in the first 1 to 2 years. And then you layer on that all of these other stressors and factors. And it makes me wonder, are we doing enough on the academic side? When we talk about readiness to practice, our lens is usually, do they have the knowledge, the skills, abilities to be safe and competent nurses? Add to that, are we really doing enough to help prepare them with the language, the reframe, the skill set to be able to take on these stressors and build resilience and focus on well-being? My gut intuition is thinking, I don't think we're doing enough.
No, I don't think we are. And it's interesting if you think about all of our DEI efforts. This is another area where there is a lot of diversity, but also a lot of stigma and bias that goes along with it. So if we were to think about how we create an environment of inclusion, we have to also think about this issue, how stigma that's perceived, that a person who's struggling is somehow irrational or not reliable. And I've learned so much about this from my colleague, Alana Bergman, who's a doctoral student here at Hopkins, and Katie Boston Leary, who has done a lot of work in this area of stigma. So how we even explore that, and from those biases, how we internalize the message that, I should be able to, pull myself up by my bootstraps and meet this challenge. And I think inadvertently, we may be in academia giving the message that, if you can't make it here, and follow the path that we've set out for you, you probably don't belong here. And then you add on to it the anticipated stigma. What are people going to think about me? If I ask for help, and then how do leaders and faculty members respond when students say, I'm really struggling? Do we accommodate? To what extent? How do we really respond to that? And then the last part is really sort of enacted stigma. It's what happens and what the experience is when you actually take the risk to ask for help. Do people gossip? Do they respond with compassion? Do they label certain individuals in a way that is really unjust and potentially disrespectful? So I think in academia, it is, for one thing, we have to look at ourselves and how we are showing up in the classroom and in our own work, how we are with each other. Students are watching. They're watching how we are together. And I think until we do that work, there's a risk that our engagement with students can sound kind of hollow. And I think we have to really pay attention to how we approach those issues together and in our schools, but also then how do we prepare them? How do we incorporate content like this into an overstuffed curriculum already? Everybody's like, oh, we don't have time. We don't have time. And so then we end up doing these sort of superficial things that don't have a lot of impact. And I think these are the kinds of behavioral tools and skills that need experiential learning. We need to have a place to practice the skills. So Michelle mentioned we've been implementing this Resilient Nurses Initiative, R3 in Maryland. And one of the things that we did, we've created first 28 modules that address various aspects of resilience and ethical practice. And then we collaborated with our nurse residency collaborative, which is 36 hospitals. So this new nurse transition piece. And we asked them where the gaps were based on what we'd already developed. And one of them was around asking for and receiving support. And so we've developed a module for new nurses and arguably for students about how to work with noticing their own, limitations and symptoms that require attention. And how do they bring those concerns to faculty or to their nurse manager if they're in a practice environment? And we included in that a script for how they could be sure that they're having a psychologically safe conversation before they talk about their concern, because there is a risk that when you have the courage to bring that up, that the person receiving it may not be skillful. So we don't want to create unsafe situations for students. And this is where I think, or new nurses for that matter, but this is where I think practice, in advance of normalizing, this is something you're going to need to have some skills in, and dedicating time to practice so that it's not a new idea.
We want to be conscious of our time boundaries. This conversation could go on, and it will. We will pick up with our conversation with Dr. Cynda Rushton on the next episode.
Thank you for joining us on this episode of NLN Nursing Edge Unscripted Surface. We hope you join us next time. Until then, remember, whether your water is calm or choppy, stay connected, get vulnerable, and dare to go beneath the surface.